to the developmental disturbances of the soft tissues. To begin with, the developmental disturbance of the lips. The first is the commissural pits, lip pits and fistulas. They are associated with other congenital defects also. It is mostly due to the failure of the normal fusion of the embryonal, maxillary and the mandibular process. It is more in adults than in children, more commonly seen in males than females. It may be unilateral or bilateral also, and it is inherited as autosomal dominant following a Mendelian pattern. Next is the congenital lip pits or paramedian lip pits. They have a hereditary pattern associated with oral clefts, higher prevalence of preauricular pits, and they arise from persistent lateral sulci on embryonic mandibular arch. They are mostly bilateral and they are inherited as autosomal dominant and associated with Van der Waals syndrome. Double lip, again it is autosomally inherited, dominant inherited, and it is otherwise called as the Cupid's bow, congenital or acquired also due to trauma sometimes. And congenital is persistence of sulcus between the pars glabrosa and the pars villosa, and acquired is in Asch's syndrome. Cheilitis glandularis, otherwise called as actinic cheilitis, It is a progressive enlargement and eversion of the lower labial mucosa that results in obliteration of the mucosal vermilion surface. Inflammatory condition of the minor salivary glands, and its potential predisposing factor for actinic cheilitis and oral squamous cell carcinoma, most commonly seen in the middle-aged and in the older men. There are many etiologies, a classification is given as simple type, superficial suppurative type, otherwise called as the Bell's disease, and the deep suppurative type. The superficial suppurative type and the deep suppurative type are associated with bacterial involvement along with dysplasia and also sometimes oral squamous cell carcinoma. Next is cheilitis granulomatosa, Melkersen-Rosenthal syndrome. It's a triad of facial palsy, recurrent swellings of the lips and the fissured tongue. The etiology is unknown, probably dietary or other antigens. Histopathologically, lymphocytes, plasma cells and histiocytes are seen within the connective tissue, and focal non-cruciating granuloma formation with epithelioid cells are seen, and especially the Langhans giant cells are also seen. Developmental disturbances of the oral mucosa, pigmented cellular nevus. They are described as haematomas, and benign proliferation of the nevus cells in the epithelium or connective tissue. They may be congenital or acquired. Three types have been mentioned: the junctional nevus, compound nevus and the intradermal nevus. Most common are the intradermal or the blue nevus, and the clinical variants are classified as small and garment nevi, and histological variants are the neural, balloon cell and the halo nevi. Histopathologically, benign unencapsulated proliferation of small ovoid nevus cells. The lesional cells have small uniform nuclei and a moderate amount of eosinophilic cytoplasm with indistinct cell boundaries. A characteristic microscopy feature is that the superficial nevus cells tend to be organized into small round aggregates. Next is the labial and oral melanotic macule. Therefore, this is focal increase in melanin, increase in the number of melanocytes. Any age it can happen, and the oral and the oropharyngeal pigmentation represents some kind of an internal malignancy or a systemic disease or some genetic syndrome. And smokers' melanosis also comes under this category, which is in adults only. Histopathologically, there is an increase in melanin in the basal and the parabasal layers of an otherwise normal stratified squamous epithelium. Melanin also may be seen free or within melanophages in the subepithelial connective tissue. Next is hereditary intestinal polyposis syndrome, otherwise called as the Peutz-Jeghers syndrome, an autosomal dominantly inherited disorder. Mucocutaneous melanocytic macules are seen. A familial history is there and usually seen in the second or third decades of life, and it may be due to the mutation of the STK11 gene. Fordyce granules, these are heterotopic collections of sebaceous glands. Inclusions of ectoderm, this is due to inclusions of the ectodermal cells with potentiality of skin during development of maxillary and the mandibular processes, mostly seen in the buccal mucosa along the plane of occlusion and on the labial mucosa. And the clinical significance is sometimes they may develop into sebaceous cysts or a sebaceous adenoma, which is described as a choristoma. Focal epithelial hyperplasia, otherwise called as a Hex disease. most contagious, may be due to HPV-13 and HPV-32. Children, young and middle-aged adults, broad-based and are reported with broad-based and slightly elevated, well-demarcated plaques, same color of the mucosa, or rarely sometimes they may be white color lesions. Histologically, they may show focal accumulations of cheilocytes in the superficial layers of the epithelium. Developmental disturbances of the gingiva. Fibromatosis gingivae, also called as the fibromatosis gingivae or the elephantiasis gingivae, slowly progressive gingival enlargement caused by collagenous outgrowth of the gingival fibrous connective tissue. They are seen as diffuse fibrous outgrowths. It may be familial or idiopathic, hereditary and transmitted through autosomal dominant gene. They may be seen in very young children or even at birth sometimes. Retrocuspid papillae, they are frequently bilateral and typically appear as a small pink papule and measures less than 5 millimeters in diameter. They are commonly seen in children, and regression of the structure with maturity is reported. Developmental disturbances of the tongue. Just an illustration for the development of the tongue. A small gist about the development of tongue. Development of tongue is due to the complex interactions between the various genes, that is PAX gene, PAX7, PAX3, PAX7, DLX and TGF-beta, which are responsible for the muscle patterning in tongue myogenesis. At the molecular level, development of tongue is influenced by molecular interactions between the cranial neural crest cells, molecules, and the myogenic regulatory factors like MYF5, muscle specific regulatory factor, MRF4, determining protein, MyoD and myogenin. Developmental disturbances of the tongue are aglossia, ankyloglosssia, microglossia, macroglossia, cleft tongue, lingual thyroid nodule, fissure tongue, median rhomboid glossitis, benign migratory glossitis, hairy tongue and the lingual varices. Aglossia and microglossia syndrome, the term aglossia implies the absence of tongue. Rare malformations are attributed to the failed embryogenesis of developmental swellings. During 4th to 8th intrauterine weeks, this is happening. Etiology may be fetal cell traumatism during the first few weeks of the gestation, mostly associated with dental agenesia, hyperplasia of the mandible and missing lower incisors. The syndromes associated with aglossia are Mebius syndrome, Hanhart syndrome, Pierre-Robin syndrome, orofacial digital syndrome, and amniotic band and glossopalatine syndrome. Microglossia, abnormally small tongue associated with oromandibular limb hypogenesis syndrome. Hypodactylia, that is absence of digits, hypomelia, hyperplasia of part of all of the limbs, and hyperplasia of the mandible, missing of the lower molars. Macroglossia, true and pseudo. Clinical features, mostly it occurs in children, noisy breath, drooling of saliva, difficulty in eating, tongue enlargement results in lisping of speech and produces a crenated lateral border of the tongue. There may be open bite and mandibular prognathism and sometimes airway obstruction also reported. So these are the different kinds or types of macroglossia and whatever is the condition. Hebifacial hyperplasia, you find sometimes a unilateral enlargement of the tongue, and especially in edentulous patients you see the tongue assumes a larger size. Mostly macroglossia may be associated with Down syndrome and Beckwith-Wiedemann syndrome. Ankyloglossia or otherwise tongue tie. It is an X-linked cleft palate syndrome. It is inherited as X-linked cleft palate syndrome with a gene mutation on the TBX22. As per Kotlow, clinically acceptable range, normal range of free tongue is more than 16 millimeters. Class 1 ankyloglossia, there may be 12 to 16 millimeters of freeness of the tongue, and class 2 moderate ankyloglossia 8 to 11 millimeters, and class 3 severe ankyloglossia 3 to 7 millimeters only, and class 4 is complete ankyloglossia of less than 3 millimeters freeness of the tongue. Clinical features, the tongue is actually fused on the floor of the mouth, and the freeness and clefting of the tip may be seen sometimes. Development of anterior open bite may be seen sometimes. There may be some speech defects, limitation of tongue movement, and feeding problems may be there. And upward and forward movement of the epiglottis and larynx results in various degree of dyspnea. The congenital syndromes that are associated with ankyloglossia is orofacial digital syndrome and then Opitz syndrome. Cleft tongue. There may be a complete cleft, that is lack of merging of the lingual swellings during development. A partial cleft, incomplete merging and failure of groove obliteration by the underlying mesenchyme proliferation. And partially cleft tongue occurs more common in deep grooves in the midline of the dorsal surface. Fissure tongue often extends to the lateral borders of the tongue and forms lobules. Numerous small grooves on dorsal surface radiating from the central groove along the midline of the tongue is seen and occurs as a sequelae to geographic tongue also sometimes. And also hereditary factors, polygenic mode of inheritance or autosomal dominantly inherited. Etiology, sometimes aging may be a cause or local environmental factors may be a cause. And grooves and furrows of 2 to 6 millimeters are present. It may be asymptomatic or a mild burning may be seen, and it is associated with the Melkersen-Rosenthal syndrome and the Down syndrome. Median rhomboid glossitis. There is a central papillary atrophy of the tongue, posterior lingual papillary atrophy, asymptomatic elongated erythematous patch of atrophic mucosa on the mid-dorsal fossa of the tongue, roughly of a diamond shape. Etiology is supposed to be failure of the tuberculum impar to retract before the fusion of the lateral halves of the tongue, and recently it has been associated with a chronic fungal infection, Candida albicans. Clinical features: lesion appears ovoid, diamond, rhomboid shape, reddish patch on the dorsal surface of the tongue, and it appears as a flat or slightly elevated area, and distinctly the rest of the tongue that part alone has got no filiform papillae. Most frequently females in a ratio of 3:1. And kissing lesions are seen, that is a midline soft palate erythema in the area of contact with that part of the tongue is seen. Benign migratory glossitis or geographic tongue. Psoriasiform mucositis of the dorsum of the tongue. Etiology: the exact etiology is unknown. It may be genetic or due to emotional stress. Clinical features: the lesion occurs in about 1 to 3% of the population. Females are more frequently affected in a ratio of 2:1. Seen on the anterior 2/3 of the dorsal tongue mucosa, characterized by multiple well-demarcated erythematous depapillated patches, typically surrounded by a slightly elevated yellow-white scalloped border and usually restricted to the dorsum of the tongue. Next is the hairy tongue, accumulation of keratin on the filiform papillae of the dorsal tongue. Etiology: chronic smokers, microorganisms like Candida albicans infection, systemic disturbances like anemia, gastric upset, and certain drugs, and also X-ray radiation. Clinical features: affects the midline just anterior to the circumvallate papillae, sparing lateral and the anterior borders. The dorsal tongue may be involved, which is involved appears thick matted appearance, and multiple individual elevated filiform papillae may be elevated. Halitosis is one of the features, and irritation of tongue due to accumulation of food debris may be there, and candidal overgrowth may also cause glossopyrosis. Histologically, marked elongation and hyperparakeratosis of the filiform papillae, and numerous microorganisms may be seen on the epithelial surface. Lingual varices is another deformity where you find a dilated tortuous vein, most commonly a vein which is subjected to an increased hydrostatic pressure but poorly supported by the surrounding tissue. Usually small in diameter, ranging from 2 to 4 millimeters. And lingual thyroid nodule: during the 3rd and 4th week of fetal life, the thyroid gland begins as an epithelial proliferation in the floor of the pharyngeal gut. Clinical features: nodular mass in or near the base of the tongue, just posterior to the foramen cecum, deeply situated and have a smooth surface. The size varies between 2 to 3 centimeters. The patient may have dysphagia, dyspnea, dysphonia, or fullness of the throat. Etiology: it occurs when thyroid anlage fail to migrate to its predestined position. Developmental disturbances of lymphoid tissue. Reactive lymphoid aggregate, also called as reactive lymphoid hyperplasia and foliate papillitis. The lingual tonsil located on the posterior part of the portion of the tongue on the dorsolateral aspect. One of the largest oral lymphoid. It becomes inflamed and enlarged, and it becomes clinically evident. Lymphoid hamartoma is another developmental disturbance affecting the lymphoid tissue. Types is hyaline or vascular type, plasma cell type, and multicentric or generalized type. Commonly, patient encounters xerostomia, and this is associated with Castleman disease. Angiolymphoid hyperplasia with eosinophilic Proliferation. Proliferation of blood vessels with distinctively large endothelial cells, seen, benign but persistent, otherwise also called as Kimura's disease. Etiology, it is idiopathic, neoplastic or reactive. Two types are there, an early lesion and a late lesion. Early lesion, rapidly proliferating atypical vasculature. Late lesion, maturation of atypical blood vessels with thickened walls and with a high prevalence of lymphoid follicles towards the periphery. Developmental disturbances of salivary glands. Aplasia, congenital absence of major salivary glands with a clinical symptom of xerostomia. Even with CT and MRI, there is absence of glands, and CT scanning with radioisotope, absence of salivary duct orifice. They may be associated with hemifacial microsomia, Ladd syndrome and mandibulofacial dysostosis. Drugs that are causing this condition is antihistamines, decongestants, antidepressants, antipsychotics, antihypertensives. Next is the hyperplasia of the palatal glands, hypertrophy of minor salivary glands. There are focal enlargement of these minor salivary glands, rarely idiopathic or associated with abnormalities. It is usually seen on the hard palate. They are asymptomatic, and we see histopathologically closely packed collections appearing with mucous acini. Lots of etiology has been listed out. For example, endocrine disorders, gout, diabetes mellitus, menopause, hepatic disease, alcoholism, Sjogren syndrome, etc. Atresia, a congenital occlusion or absence of the major salivary gland ducts, and formation of retention cyst and xerostomia are commonly encountered. Thank you all. Thank you so much for the patient listening. Hoping that little bit of revision has happened with the first chapter, and of course the topic is very extensive with lot of entities, but still I see this as a long essay in the recent advances paper. I hope my presentation would have helped you to a certain extent at least. Thank you all so much.